Warning: this podcast does not introduce any new information outside the Foundation's curriculum. Listener discretion is advised.
Hey there, Central Liners. Welcome to Real Doctors, Real Friends, the official podcast of Foundations of Medicine. I am your host, Roshan, along with my partner in medical education, Shereen.
Hi, everyone. Congratulations on completing week 5 of Foundations. We hope you had a great week immersed in our themes of neurophysiology and musculoskeletal, or MSK, systems, along with your clinical skills and physical exam sessions.
This week really pushed us to integrate basic science with clinical realities, from understanding action potentials and energy metabolism to confronting the complexities of chronic pain and accessibility.
Absolutely. Our case study, Mr. Suriv, gave us a deep dive into the nervous system and pain pathways, while Greg's story challenged us to step into the leader role and advocate for systemic change.
So let's start with chronic pain, a thread woven through both this week's cases. Mr. Suriv's, in the initial diagnosis of shingles, or varicella zoster virus /VZV, led to persistent pain known as post-herpetic neuralgia. And just to break that down, post, after, herpetic, the herpes virus, which is the main family of the varicella zoster virus, and then neuralgia, which is pain involving the nerves. He was prescribed opioids to manage this ongoing condition.
And this transitions perfectly to Greg's experience with chronic pain following his spinal cord injury, or SCI. Chronic pain is complicated at every level of the biopsychosocial model, and Greg articulated how his pain was blinding, making him feel like a lost cause.
Given the depth of Greg's pain and frustration, it is absolutely critical that we, as future clinicians, learn to describe strategies for communicating the pathophysiology of a spinal cord injury, or SCI, to a patient. This communication is a core learning objective from Greg's story.
Exactly. Communicating the science clearly means detailing the specific site of spinal cord injury. We also need to explain the patterns of innervation, including what tissues receive motor commands, or efferents, and what tissues relay sensory information, or afferents, to communicate with the brain. This helps the patient connect the injury to the specific impacts on function and sensation that they're experiencing. So things such as the loss of sensation, loss of motor control, or loss of bladder control, which was really frustrating for Greg.
And relating that biological injury to his chronic pain is equally vital. When describing pain, we should cover how it is defined, including the difference between direct and referred pain. We must also explain that the shift from acute to chronic pain is something that we don't completely understand yet. This can help acknowledge a patient's pain experience as well as their frustration when available treatments are not effective. We can even share the state of our knowledge right now, such as describing inflammation and the remodeling of neural connections or reorganization of neural circuits.
I imagine a way to approach that is to share that healing after an injury or infection is a normal and healthy process, but sometimes it can lead to changes in our nerves, and that can cause us to feel pain more intensely. Another thing we can do is acknowledge the broader context of pain modulation. The modulation of pain perception is influenced by pharmacological interventions. So usually these are drugs that have some effect on the nervous system, such as modulating synaptic transmission and electrical activity. But it's also significantly altered by factors like stress, which can lead to increased sympathetic nervous system activation and can factor in profound impacts of mental health, furthering stress, and contributing to the lived experience of pain. So this holistic approach to communication helps validate the patient's experience. And this reminds me of something that maybe we touched on a while back. Sometimes it's okay to let the patient know that we don't know something, that there are gaps in our knowledge, and it's absolutely critical to address those gaps. And there are lots of people in other fields doing research to try and address those gaps, or try to develop new modalities for pain relief. Even acknowledging that can help a patient feel a little bit less frustrated and less alone in their struggle.
I totally agree. And I can tell you that it helps in real life.
Mm-hmm.
As long as I think the concern for students at first is sort of showing that vulnerability when
Yeah.
you're starting off
Mm-hmm.
seems like a tall order,
Mm-hmm.
right?
You want to feel like, or you want to relate that you know everything. You know a lot of information, so the patient can trust you. So I can understand why somebody might be hesitant to disclose that we actually don't know.
But once you've established a good enough relationship with the patient and once you feel comfortable being vulnerable, and it's a common theme throughout foundations that I like to talk about,
Mm-hmm.
I do think you can significantly affect not only the course of that patient's pain, but also the relationship
Yeah.
by just acknowledging, as you said, and being vulnerable about the fact that we don't completely know what's going on sometimes.
Yeah.
And trying to explain things as best as you can,
Mm-hmm.
and then making them feel as part of the plan,
Yeah.
I think is really important.
The shared decision making.
Shared decision making. Yes, always keeping in mind that we treat the patient as a whole person as opposed to focusing only on the mechanics of pain. As I mentioned in my field, the implications of chronic opioid use in primary care are immense. Primary care often becomes the default manager for chronic pain medication. We learn that medical and social complexity are frequently interwoven with chronic opioid use, and clinicians like myself often lack the time necessary to manage this condition effectively.
Speaking of complexity, the overall financial burden of chronic pain is staggering. In Canada, the total direct and indirect cost was estimated to be 38.3 to 40.4 billion in 2019. So I'm sure it's gone up since then.
And this is why physician advocacy is so vital. We discussed interventions for patients struggling with opioid use disorder, or OUD, such as learning where treatment specialists are located, educating patients and their families about OUD signs, ensuring staff are trained to use naloxone, and advocating for systemic policies that promote safe prescribing and addiction treatment accessibility. I am extremely excited, though, about some of the non-opioid pain medications that might be on the horizon.
Yeah.
One of which is suzetrigine. I believe that's how it's.
I think so.
And we're not saying the brand name. We're just using the generic name.
Yeah.
At this point, and it's sort of going through the official approval process. I don't think here in Canada we're at that stage yet.
Yeah.
But really exciting, and relating back to content from foundations, it's a really cool mechanism because it's not a central acting
only in the periphery.
Only in the periphery.
Yeah.
So a lot of those side effects that we see with centrally acting pain medications is not seen here because it's actually working in the periphery.
Yeah.
And it has an allosteric effect.
Ooh, there we go.
And more selective, I believe, sodium channel involvement.
Yeah.
So that's actually really cool just in terms of the application to what we're learning in foundations right now. So hopefully we can see a little bit more of that as time goes on.
So more of a selective mechanism only affecting the peripheral nervous system as opposed to the CNS, and thereby we avoid a lot of the dangers of opioid-based medications. That where you get that respiratory suppression that ultimately can be fatal. So very interesting. We'll see what happens with that one.
Definitely.
So our story of the week did highlight the leader role, and this is about fostering healthcare improvement at multiple levels. Greg's story specifically showed us how physician leadership can facilitate change in healthcare policy around accessibility for patients with spinal cord injury. This includes advocating for social policy reform, covering necessary items like catheters and equipment, along with ensuring proper fitting and appropriate pricing for that equipment.
Now let's turn to some of the fascinating science from the week, largely drawn from the Mr. Suriv case, but also seen in a lot of your lectures. He presented with sharp, persistent flank pain and an erythematous vesicular rash presenting at the T7 dermatome.
That term, dermatome, is crucial. A dermatome is defined as a section of skin corresponding to sensory innervation from a single spinal nerve. The discovery that Mr. Suriv had shingles caused by the varicella-zoster virus highlights that this virus remains latent inside neural structures such as the dorsal root ganglia. Spinal nerves, which supply these dermatomes, are part of the peripheral nervous system and not the central nervous system.
Later in his story, Mr. Suriv was diagnosed with myasthenia gravis, or MG, a condition characterized by muscle weakness. We reviewed how signal transmission at the neuromuscular junction, or NMJ, works.
That's right. And through our case study, we clarified a couple of important false statements. One was the presynaptic neurons release acetylcholine, which binds to receptors but is not absorbed by the postsynaptic muscle fiber. So, an important note to make that distinction that acetylcholine actually has to bind to nicotinic receptors in order to elicit muscle action. And we also cleared up that the action potential is propagated by T-tubules, not myofibrils. So T-tubules to the sarcoplasmic reticulum. And the sarcoplasmic reticulum, that's like an intracellular store of calcium.
Yeah.
That's going to promote the release of calcium into the cytosol, which is important for that neuromuscular coupling. As an aside, myasthenia gravis is an autoimmune condition where autoantibodies develop against nicotinic receptors, which means that there are fewer receptors for acetylcholine to bind in the neuromuscular junction, which results in that muscle weakness upon presentation.
And when Mr. Suriv darted away from those wasps in the case, his skeletal muscle, facing high oxygen demand leading to ischemic conditions, had to rapidly mobilize fuel. The preferred energy source used first for fast and explosive movement is stored ATP.
And in those ischemic conditions with low oxygen levels, and after a great deal of time has passed, glycolysis and the conversion of pyruvate to lactate becomes the predominant metabolic pathway as opposed to stored ATP, which would have been exhausted by that time.
Shifting away from biochemistry concepts to radiology, we learned about different imaging modalities like X-rays, computer tomography or CT, ultrasound, and magnetic resonance imaging or MRI. And importantly, we learned about the Choosing Wisely Canada campaign, which aims to help physicians and patients make effective choices by avoiding unnecessary tests and procedures, such as avoiding imaging for lower back pain unless red flags are present. A great callback to the leader role in the CanMeds framework.
Yeah. You know, when we think about the Choosing Wisely Canada campaign, is the purpose of the campaign more so to conserve resources, like from an economic perspective, or is it about avoiding the need for a patient to undergo a test that might be uncomfortable or even stressful, like being confined in an MRI apparatus?
I think, as is the case in a lot of our institutions, it's about efficiency.
Driven by dollars.
Driven by dollars. I mean, we still say it's a little bit of both because unnecessary imaging as well as lab investigations are a problem in all of medicine, and especially in primary care medicine, where we're faced with a lot of uncertainty, but we do have access to these outpatient options. And so we take advantage of that, especially when that uncertainty is there. But the campaign is a very strong one and was definitely initially developed with the aim of resource stewardship.
Yeah. I imagine some tests would be really arduous for some patients, and if you could avoid them, then that would probably be better.
That is definitely the case for a few tests, MRIs being one of them. It's a conversation I have to have with patients not infrequently, where I have to tell them, hey, you know what, I have to explain to them what actually happens with an MRI in order for them to be like, oh, well, you know, maybe I might actually need something to take with me because it might actually make me feel a bit nervous.
Yeah.
Some of the other procedures that are involved for diagnostic purposes are anything that involves sort of an injection, right? Where you
or
have
like
a dye.
endoscopy or colonoscopy. I think those can be very difficult for people. So if it's not necessary, don't make your patient do it. You know, using the example of lower back pain, why is it usually unnecessary to order imaging in that case? Like when you have a patient that just says, this is where I have pain.
And I want to be clear, it's not that it's unnecessary to order imaging, it's that we need to be very careful with who we order imaging for. So when there are red flags, or sometimes what they call yellow flags, which are sort of in between, but definitely red flags where we're concerned about more radicular symptoms, so where there is potentially more of a compression that's going on at a nerve root, potentially, or potentially in the spinal cord itself. Right, where the central spinal cord itself, where we're a lot more worried, and that has definite implications. And that's actually why X-rays aren't as useful from a diagnosis standpoint when it comes to what we typically call lower mechanical back pain. Having said that, when arthritis or what we call degenerative disc disease or changes in the disc structure of the spine are likely to create pain and
Mhm.
problems for patients. And X-ray can sometimes be helpful to help guide treatment
Okay.
that is not surgical.
Okay.
And so I think
Yeah.
that's ultimately the main reason for why we try to dissuade imaging is
Mhm.
because for the vast majority of people, surgical options are not off the table,
Yeah.
but they're limited.
And it's probably one of the last options
Yeah.
because, I mean, the surgical intervention has its own complications too, can make things worse.
And that is exactly the
Yeah.
reason why we really try to avoid it.
Yeah.
And so if you're going to do the imaging test, usually
Mhm.
it means that it's pointing you either towards a specific diagnosis or more than likely, especially in primary care and beyond, treatment.
Yeah.
Right? So if you have an idea about certain treatments, so injections,
Mhm.
are especially the ones that we think about for guided treatments that an X-ray could actually tell you a little bit about.
Mhm.
If you're doing it for that purpose, sure, but then
Yeah.
you have to still have a reason for it because there's only certain types of injections that actually work for chronic back
Right.
pain, right?
Yeah.
So the vast majority of people, though, we're looking at sort of the whole picture of chronic back pain, which is, first of all, chronic pain in general,
Yeah.
the perception of pain,
Mhm.
the element of sort of rehabilitation,
Yeah.
right? When it comes to mobility, when it comes to core strength,
Mhm.
and then just overall wellness when
Yeah.
we're talking about chronic pain.
Yeah.
And those are the things that we should prioritize. But when someone's sitting in front of you and asking for an X-ray, doing all of that
Yeah.
versus just sending for what we oftentimes say in primary care, a therapeutic
Right.
diagnostic
That's
imaging
true.
test.
That's true.
Right? And that's, I think, where choosing wisely is really important,
Mhm.
where it's telling us to actually question things a little bit
Yeah.
more. And it's directly involved with the leader role,
Yeah.
where we talk about resource stewardship, which I think is a great callback to the story of the week.
Yeah.
Yeah.
You're right. Maybe, especially a patient that's been struggling for a while, they might think that the X-ray holds the answer to all of the pain that they're experiencing. So maybe it is worthwhile
And
to
a
send.
callback to all the way back to the group reflective activity. This is where knowing your medical expert content can make you a better leader and vice versa.
Yeah.
Because if you can know your medical expert content well enough, communicate it to the patient,
Mhm.
you've actually become a leader if you've been able to have that resource stewardship in mind
Yeah.
and actually save the system some money.
And explain what an X-ray will show you and what it can't, and
Yep.
whether or not it's appropriate for them.
Yep.
Yeah. Okay. Well, those are really interesting points to consider, and I'm sure they'll come up again for our listeners. Now, after a busy week, it's time to unwind and have a little fun. So, how about we check out the results of our polls, Central Liners? Let's start with our debate on the optimal study tool for knowledge retention.
Fiercely fought battle based on pharmacological mechanisms. The clear winner, receiving 37% of the vote, was D, keyboard. This choice prioritized extensive tissue distribution, i.e. high apparent volume of distribution, to maximize input and widespread documentation across digital folders.
Coming in for second place at 23% each was stylus. So this is efficacy with a safety ceiling and partial agonist. This suggests our central liners are split between prioritizing long-term integration and rapid, safe, functional activity. So I guess the pen and paper is not
Not as
a
much.
big hit with our central liners this year.
The bigger question was about pumpkin spice. So we have our results from our philosophical pumpkin spice latte or pumpkin spice debate from a while back. The top two choices were B, goal setting, 32%, viewing the treat as a reward after retrieval practice, and A, positive self-talk at 29%, seeing it as a break for self-compassion and recovery. Our listeners are disciplined, but also kind to themselves.
So I guess it's a tie because
Yes,
you
I'd say
won
that's
the
effectively
learning
tied.
tool.
Yes.
And I won the pumpkin spice. So we're even. We're even.
Yes. I wasn't actually, I kind of expected keyboard to be that much.
Yeah? Oh, okay. Yeah.
And now the true test of our friendship. 90s fashion and trash talk TV. Should it make a comeback in 2025? Yes or no?
Absolutely, yes. And I say that as a kid that came home from school and watched Jerry Springer and all those shows.
I feel like I'm reluctantly engaging with 90s fashion because the kids are doing it. So I feel compelled to do it. Also, maybe it's a a middle of the road. Maybe I'm a soft yes.
Okay.
Because as I get older, it's just more comfy.
Yeah.
Right? Like the millennial 2000s tight jeans, everything
Yeah.
tight.
No.
I'm
That's not good.
I'm going to be heading in my 40s soon. Like I don't want to do that anymore.
You don't want to wear
right?
that. Yeah.
But I feel more of an affinity to that style than the 90s style because I hated the baggy jeans
Oh, really?
when I was growing up. I asked, it's funny, like I had, it was a war inside my mind because I would ask my mom for them
Yeah.
because everyone else had them.
Yeah.
But secretly I wanted tighter
Yeah,
pants
you wanted
I
the slim
did not like the baggy jeans.
So what do you think now about the extra baggy trend? Have you seen that?
Oh yeah, no, I have.
That's extreme.
Oh, I definitely have. And I think it works well for our younger people. That's not fair. But if I see somebody above the age of 50 rocking that, I say hats off. They're probably pulling it off, but it doesn't hit the same way.
Yeah.
I don't know. That's
so far I've only witnessed it on like very, very young people, like junior high
I saw
school.
one of my specialist colleagues who was a few years ahead of me.
Wearing the super baggy?
Oh yes.
Oh my gosh.
I'm gonna guess he might be my age actually, but he was a few years ahead of me in residency and medical school, so he's quite a bit older than me. I saw him rocking that, I think last year.
Oh wow, ahead of the game.
Oh, big time.
Ahead of the game.
Big time.
Yeah. Well, I like the 90s makeup, the 90s look, the brown lipstick. Like that was huge then, and
That's
I'm so happy that it's back now. Like and you see like young influencers, it's really funny, and they're presenting it as if it's like this brand new thing on the scene.
That.
I'm like, this is not brand new.
It's not brand new.
We've been doing this for a long time.
And what about trash talk TV? I never got into that. I never ever got into that.
You know, my parents never really thought it was a big deal.
Yeah, we were talking about this before we started recording.
I would come home from school and like have a after school snack and watch Jerry Springer and watch Maury Povich.
Because what else would you
Ricky
do?
Lake. Yeah, I know. Like all of those. I watched all of them.
Wow, Ricky. Yeah. I have not heard that name in so long.
Yeah, I watched all of them.
Wow.
Like by comparison, Oprah was very responsible and was like, that was investigative journalism, compared to all of the others.
I love that that's the analogy you're using. Oprah equals investigative journalism.
Like, by comparison.
So from an SAT test standpoint, if Oprah is investigative journalism, what is Jerry Springer?
Oh my gosh. I don't know. All you have to remember
like
is
run and gun. Yeah.
Jerry. That's all you need to remember.
And you felt there was a bit of a decline in the quality of Maury's because it started to devolve into more of like paternity testing.
Yeah, it was like, you are the father. You are not the father. It was less, about, the different scenarios and kind of the juicy gossip style things that Jerry Springer and Ricky Lake were delving into.
So in Ottawa,
scandals.
we didn't have cable.
Yeah.
So I never saw Jerry Springer.
Oh, no way.
But we had access to Maury for whatever reason.
Okay.
But it was only during the day.
Okay.
So it was only during the day.
Yeah.
So it was only when we were sick that we might get to see it.
You had an extra treat.
Maybe. But I
help you feel better.
But my anxiety would just get so ramped up when I would watch it. I hated it because I was so anxious for everybody on the show, except for Maury, who's just like sitting
relaxed,
there, like opening it up and being like, "You are the he seems so relaxed," but everyone else seems on edge. Or I felt anxious for them.
Yeah.
So like I actually felt that Oprah was calming.
Yeah.
Right. Or Ellen knows too much later.
Yeah.
But that was definitely anxiety provoking.
Yeah.
So that's the reason why I didn't like trash talk TV.
Yeah.
That is exactly why I didn't
I
like
liked it because it was salacious and I was like a junior high kid at the time.
Yeah.
So that's kind of where your brain is curious.
Very true.
And you're also at that stage where you tend to believe a lot of the things. Like you don't understand that it's probably exaggerated, that it's acting. So then, and it's so different from what you experience in your day-to-day life. So, I mean, of course, there was a pull to watch it, but those shows didn't age well, to say the least.
I think you're absolutely right.
Well, there it is, Central Liners. Help us settle this debate. Let us know if you think 90s fashion and trash TV should make a comeback. And we'll reveal the results in our next episode of Real Doctors, Real Friends.
Have a great weekend, Central Liners, and congratulations on completing week 5 of Foundations. Take care, everyone.